So it might be helpful to also take a quick step back and just level set on FHIR in general, because it is such a common foundation to the interoperability mandate and these APIs. So FHIR stands for Fast Healthcare Interoperability Resources, and it's a standard for exchanging health information electronically. It was developed by HL7, a leading standards development organization for medical data in the US and internationally. And FHIR, what it essentially is a language for health data that allows information to be exchanged and understood across organizations and applications using an API, that application programming interface. And there are four things that are unique and make FHIR quite special as a data standard. There are other standards out there. There's, EDI standards, there's the CCDA standard, there's HL7B2 standard, but FHIR has four unique things about it. First, FHIR is a standard for both data transport, specifying how healthcare data is transferred from point A to point B, but it's also a content standard, specifying specifying how data can be transferred. So that combination of saying both how data should be transferred and how that information should be structured is very unique. Also, FHIR uses more modern technology, so it supports four different interoperability paradigms. It supports REST, JSON, XML, and RDF, and it's also open source, so it's free. And then finally, FHIR is broken down into more granular response or resources, which make it a much faster and more nimble and easier way to exchange data that provides a lot more efficiency and agility. So all four of the APIs that we've been discussing in that interop rule specify FHIR as the chosen standard of data exchange, and CMS in general is making a big, big push toward FHIR being the future standard of data interoperability. And the pair-to-pair rule requires the use of FHIR and strongly recommends the Payer Data Exchange or PDex Implementation Guide. This is what I was referencing earlier in our conversation. And that PDex Implementation Guide, it's designed for payers and health plans to help them create a member's health history using clinical resources based on the FHIR R4 standard. And this information can be understood by providers and, if they choose, also integrated into their EMR systems. So the Vinci PDex Implementation Guide, it serves as this use case implementation roadmap for health plans to really navigate the process of payer data exchange. However, health plans who have attempted to establish connections in the real world, and as we encountered working with our health plans in our first cohort of pair-to-pair connectivity, we found that there were some hidden challenges that the implementation guides did not capture. And that's why we established this cohort program with 3 national health plans. Availity officially initiated its first cohort back in August in 2023. And, we met consistently with different participants and really collaboratively were able to address 2 fundamental questions. First, how do we uncover any hidden challenges or pitfalls associated with the pair-to-pair connections? And secondly, how do we determine the most effective and repeatable process for establishing connections with other payers, particularly around these gray areas of the implementation guide? How can we design a multi-payer approach and a standard approach to really drive and scale connectivity?